Hi everyone, my name is Steven. I'm in the Family Nurse Practitioner program and I'm here to speak to you about a project proposal for implementing an observational approach to treating non-severe acute otitis media, or AOM. This infection is a common childhood illness that affects 50 to 85% of kids by the time they're 3 years old. This equates to hundreds of millions of new infections across the globe every year. The US is traditionally one of the countries that treats this infection with immediate antibiotic use. One article from the Cochrane database estimates that about 95% of our infections here get treated with antibiotics. Because of the growing concern of antibiotic-resistant bacteria and the infections they create, more research is into treating this infection without antibiotics has been done. The literature reveals that an observational approach with symptomatic management is safe and effective for treating non-severe cases of this illness. The 5 studies that were reviewed all had some commonalities. Between 62 and 85% of the control or placebo groups finished their study without using antibiotics. The Kujala study was an outlier with only about 41%. All the studies also found that antibiotic use in general attributed to faster symptom resolution time, but also increased likelihood of adverse reactions like diarrhea, vomiting, and rash. The last common finding was that the placebo or control group often used more analgesia during the course of their infection compared to the antibiotic group. This intervention will focus on children between 6 months and 3 years of age. This age group is selected based on the fact that a high percentage of children experience this infection and that existing studies that were reviewed focus on this age range. Applying these research findings to an age group that were used in the studies is the safest way to apply them as a change to practice. In addition, the prevalence of infection within this group will allow for data to be gathered quickly and allow findings to be applied to the majority of people that experience these symptoms. A total of 250 children will be recruited for this study. The intervention will take place in a primary care location. This will ensure that family and patients know the provider and may feel more comfortable trying an uncommon style of treatment. This setting is also a safety factor, allowing patients to easily get follow-up care if needed. All providers will receive training on how to diagnose acute otitis media accurately. This includes the use of findings from otoscopy and tympanometry. Criteria for diagnosis comes from the American Academy of Pediatrics. Using these, children will be diagnosed with non-severe AOM. The provider will briefly describe the disease process as well as the intervention and obtain consent for parents and assent from the children. Participants will go home with prescriptions for analgesia and amoxicillin. The antibiotics are only to be used if a child's otalgia and fever continue for more than 48 hours total. Parents will be asked to write in a log twice a day about the incidence of otalgia and fever, the amount of analgesia provided, and, if needed, the start and administration of antibiotics. This will go on until symptoms have resolved and the medication use has stopped. A research assistant will contact the family on day 3 to identify if symptoms are continuing and to see if antibiotic prescription will be used. The child will be asked to come in to the care site on day 12 for an in-person assessment. The provider will assess the child's vital signs, otalgia, signs and symptoms of adverse reaction, and look at their tympanic membranes. If infectious symptoms continue after the use of antibiotics, the child will be referred to an otolaryngologist. On day 30, the research assistant will again call the parents, asking about lingering otalgia in either ear, fever, and medication side effects, and help in assisting to make a follow-up appointment with their provider if needed. All the notes taken by the parents will be collected and analyzed. It is expected that about 60 to 75% of the participants will be able to resolve their symptoms without use of antibiotics. The actual number of participants with treatment success will be compared to this estimate and will decide interventional success. The estimated direct and indirect costs of this intervention is $31,980. Some of the benefits that we'll see implementing this intervention include the emphasis that using non-antibiotic therapy as a frontline treatment for non-severe AOM is safe and effective. This intervention also highlights the importance of strict diagnostic criteria, patient-provider decision-making, symptom management, and appropriate antibiotic use if indicated for AOM. The observational approach allows the patient's natural immunity to experience this infection, provides a lower chance of uncomfortable side effects, and reduces the chance of developing an antibiotic-resistant bacterial infection. It will help to decrease the 2 million associated infections and 23,000 deaths per year, all resulting from resistant bacterial infections. And finally, enacting the intervention will provide information to those who are interested in implementing this plan into their primary care setting or in other settings like clinics, minute clinics, and emergency departments. Thank you very much.